In this video, we are going to discuss about the prostatic urethra and the prostate. Okay, so first we'll start with the anatomy of bladder. If you see the bladder, it has a trigone in middle, right? So this trigone area is inside the bladder, and if you see there are no rugae because the submucosa is absent here, and the mucosa is also thickly adherent to the detrusor muscle. So because of this, there are no rugae formation. And if you see the bladder, it is of endodermal origin, but if you see this trigone is especially the mesodermal origin. Okay, and the trigone in between the two ureteric orifice, you can see an interurethric or Mercerius bar, and this is interureteric ridge. Okay, and no rugae in the trigone, and they together form the apex here. Now coming to the urethral crest, you can see here from the trigone below it will continue as an elevation that is called as urethral crest, a small elevation due to trigone of bladder. Next, what is colliculus seminalis? It is a verumontanum. It is also called verumontanum. The urethral crest only expands to form the colliculus seminalis. So you can see this is a colliculus seminalis. Because of expansion of urethral crest only this is formed. And this colliculus seminalis have three openings. That is two from the ejaculatory duct and one from the prostatic utricle. Okay, so three openings, two ejaculatory duct which are formed by vas deferens and seminal vesicle which is derived from mesonephric duct. If you see the prostatic ureticle, it is also forming a cul-de-sac which is a remnant of paramesonephric duct in the male. Now coming to the anatomy of prostate gland. So the prostate gland, especially its median lobe, this is called as median lobe of prostate gland. The boundaries are, if you see anteriorly there is prostatic urethra, and if you see posteriorly there is ejaculatory duct, and if you see at the base it will extend into the bladder to form a uvula vesicae. So you can see here this is a uvula vesicae. Uvula vesicae, the base of median lobe extend into bladder, form a tongue-like projection. So it is a base of median lobe extending into bladder, and it is forming a tongue-like projection. Uvula vesicae enlarge in BPH, that is benign prostatic hyperplasia, where there is a stagnation of urine seen. So you can see in this diagram clearly. This is an enlarged median lobe of prostate, that is uvula vesicae, and here you can see this is a pouch of stagnant urine. This is a bladder wall. This is the ejaculatory duct. This is the posterior lobe. This is the urethra, sphincter, vesicle. So now coming to the lobes of prostate gland. So you can see here, this is a prostatic urethra. This is the median lobe. This is the lateral. So these are the two lateral lobes. This is the posterior lobe. This is the anterior lobe. So we'll see now median lobe. Median lobe lie behind the crescent shaped prostatic urethra. Two lateral lobes lie on either side of prostatic urethra. Posterior lobe is both lateral lobes continue behind median lobe as posterior lobe. Anterior lobe, both lateral lobes continue in front of prostatic urethra as anterior lobe. And anterior lobe doesn't contain any glandular part. It is also called as isthmus. So this is also called as isthmus because no glands here. Now we'll discuss about the zones of prostate gland. So for that, first I'll show the diagram. Next we'll see the theory. So you can see here these are the different zones. This zone is called as transition zone. Near the ejaculatory duct, this zone is called central zone, and this zone is called peripheral zone. So let us see what is there in the theory. So zones of prostate gland. The transition zone is surrounding the proximal part of prostatic urethra. It's in the proximal part. Benign prostatic hyperplasia is more common in transition zone. Okay, so BPH more common in transition zone. It is the proximal part of prostatic urethra. Central zone. It is surrounding the ejaculatory duct. Here the carcinoma is less than 2% chance, and it's highly invasive because it is involving the ductal system. Because as the ducts are there, it is highly invasive. So there are like ejaculatory duct, seminal vesicle, vas deferens, epidermis, all are connected to this central zone. So there is a high invasive nature of this cancer. Now coming to peripheral zone, it is surrounding the distal part of prostatic urethra. So the transition zone is in the proximal part of prostatic urethra. Peripheral zone is in the distal part of prostatic urethra. The carcinoma is most common here in the peripheral zone. 80 to 85% chances in peripheral zone. but it is asymptomatic initially, but in advanced state it will compress the prostatic urethra, giving rise to obstructive or pressure-like symptoms. Now coming to the blood supply of prostate gland. Can you remember the mnemonic? Mr. X admitted as a patient and he received the IV. So Mr. X, here Mr refers for middle rectal artery, and here IP inpatient, IP refers to internal pudendal artery, IV refers to inferior vesical artery, or even you can remember them, it's okay. Prostate gland is supplied by middle rectal, internal pudendal, inferior vesicle. Okay, so a counterpart of prostate gland in female is a paraurethral gland of skin. Okay, now coming to the different layers of scrotum. So these are derived from layers of abdominal wall. The dartos muscle is subcutaneous muscle. Transverse abdominis muscle doesn't contribute to layers of scrotum. It is not involved. Only fascia transversalis is involved. So layers of abdominal wall, from them these are derived. So skin is same skin, first layer. Next the dartos muscle, which is subcutaneous muscle. It is nothing but derived from superficial fascia of membranous part. And external spermatic fascia, which is derived from external oblique muscle. Cremasteric muscle and fascia are derived from internal oblique muscle. Internal spermatic fascia is derived from fascia transversalis. Let us see the nerve supply of scrotum. It is supplied by, especially its anterior 1/3 is supplied by ilioinguinal nerve and genital branch of genitofemoral nerve. But its posterior 2/3 is supplied by posterior scrotal branch of S3 perineal nerve and the perineal branch of posterior cutaneous nerve of thigh S3. So this is supplying the posterior 2/3, anterior 1/3 by ilioinguinal and genital branch of genitofemoral.